So very good morning, everyone present here. Good morning, Dr. Rohini. Good morning, Dr. Rashi. Today is this 13th online teaching class under the banner of Up-Aroi. So for this moderation, I would like to invite Dr. Rashi. She's the principal consultant, Max Vaishali. Dr. Rashi, it's over to you.
Thank you so much, Dr. Sudhi. This is our 13th class, as Dr. Sudhi has mentioned. And this class is going to cover very important aspect, that is radiotherapy in nasopharynx. And you know, as the role of radiation is now actually reducing, but the role of radiation in carcinoma nasopharynx, it is a radical one. So as being radiation oncologists, we should know how should we treat and what are the protocol. And none other than Dr. Rohini Khurana. She is professor in Department of Radiation Oncology of RML Institute, Lucknow. She is a very good teacher, and we are actually highly privileged. She is here and going to take a lecture on our radiotherapy in carcinoma nasopharynx. Thank you so much, ma'am, for accepting our invitation. So over to you, Dr. Rohini Khurana.
Thank you, Dr. Rashi. So a very good morning to all. And at the outset, I wish to thank the UP chapter of ROHINI for organizing these webinars in the interest of PG students. Professor Shalin, Professor Surabhi, Professor Ashutosh, and Dr. Rashi, your concern to uplift academics is really inspirational. Under this series, today I'll be discussing management of carcinoma nasopharynx. So, now carcinoma nasopharynx is different from other head and neck cancers in terms of that there is a remarkable variation in racial and geographic distribution. While it is endemic in the East and Southeast Asian countries, where around 70% of the cases are found, and the incidence rate is around up to 50 per lakh for those in China, Hong Kong, and Southeast Asian countries, it is only about 0.2 to 2.5 per lakh in Caucasian population. So we can see the difference in the geographic distribution of this malignancy. The another difference from other head and neck cancer is its association with Epstein-Barr virus. Also, there are various histologic subtypes of nasopharyngeal cancer, and they have an aggressive natural behavior and higher predilection for distant mets, especially the WHO type 3. Now, what are the histologic subtypes? WHO 2015 classification says that type 1 is keratinizing squamous cell carcinoma. They are the sporadic form and seen in around 25% of the patients. Now, keratinization in itself is a poor prognostic factor. These WHO type 1, they have a poor local control and lesser propensity for distant mets. The WHO type 2 or the non-keratinizing differentiated form seen in 12%, and the non-keratinizing undifferentiated one or the WHO type 3, it is the most common or the endemic one. Now it has a very good local control, but there is a higher risk of distant mets with non-keratinizing undifferentiated or the WHO type 3. And this is the one, type 3, which is most strongly associated with Epstein-Barr virus exposure. Another variety, the basiloid, is extremely rare. So as we know that the nasopharynx, it is in the form of an inverted pyramid, and the superiorly it is bounded by the sphenoid, and posteriorly it is bounded by the base of skull or clivus, Inferiorly, there is a soft palate, and anteriorly, there is the nasal cavity. Now, what are the presentation of patients with nasopharyngeal cancer? So, depending upon the local or the nodal spread, the presentation can be with a neck mass. Now, nodal mets are as common as more than 60% in nasopharyngeal cancer, and bilateral nodal mets is as common as up to 50%. It can present with epistaxis due to extension into the nasal cavity, as headache or diplopia due to involvement of the cranial nerves, facial numbness, otalgia, or nasal congestion. Trismus and or cranial nerve deficits are seen with more advanced disease. So, what are the diagnostic tests? What is the workup that we need to do prior to embarking upon the treatment? We need a complete history and physical examination, a complete blood count and serum biochemistry, an endoscopy and biopsy of the nasopharyngeal mass, and preferably with a fish for Epstein-Barr virus RNA, CT scan or MRI of the nasopharynx and base of the skull and neck. Now, MRI is preferred because it has better soft tissue delineation. It can make out marrow involvement, parapharyngeal extension, differentiate retropharyngeal node from the nasopharyngeal mass, can make out perineural spread, optic chiasma, and hippocampal involvement. For these reasons, MRI has a superiority over CT scan. For distant mets, a PET CT, or in case it's a primary neck with unknown primary with the nodal mass, then a PET CT. Baseline audiometric testing, complete death knell prophylaxis, along with fluoride application and removal of any carried teeth if present. Nutritional status evaluation, as there will be mucositis during treatment, and either patient needs to be built up prior to treatment, or we must counsel him regarding need for a Ryle's tube later on. Complete cranial nerve examination, ophthalmologic and endocrine evaluation. Now, plasma Epstein-Barr virus DNA has a value in prognostication of disease and quality of life assessment. There are ESMO-URAC and clinical practice guidelines for diagnosis, treatment, and follow-up published in 2020. And these are the level 3B recommendation, are highly recommended. So 3B is the level of recommendation as per these clinical practice guidelines. Coming to staging, now the AJCC 8th edition has some changes in staging of nasopharyngeal carcinoma as compared to the previous staging. While T0 is no primary identified with Epstein-Barr virus positive cervical nodes, T1 is extension to the oropharynx or nasal cavity without parapharyngeal involvement. T2 is parapharyngeal extension with adjacent soft tissue involvement. Now, they have included the prevertebral muscle in T2 now. And T3 is involvement of the skeletal structure, the base of skull. And T4 is intracranial extension and cranial nerve involvement. Now, there are some changes in the nodal staging also. Unilateral cervical less than 6 centimeter or retropharyngeal less than 6 centimeter is N1, we all know, but now they are considering whether the nodal involvement is above the caudal border of cricoid or below it. If it is above and less than 6 centimeter, then it is N1. If it is bilateral less than 6 centimeter but above the caudal border, it is N2. If it is more than 6 centimeter or extending or involving below the caudal border of cricoid, then it is N3. So the involvement of the lower nodes is now N3. And this is well justified because with the involvement of the lower neck nodes, there is high risk of distant metastasis. So the changes are that the masticator space extension or the involvement of prevertebral muscle to the lateral is now T4 versus is now T2 versus T4 previously, and supraclavicular node involvement is now consolidated with N3 disease. Radiotherapy, as has been mentioned, is the mainstay of treatment because it is a radiosensitive tumor with the limited role of surgery due to its anatomic location. The clinical outcomes with radiotherapy have improved significantly due to advances in high precision radiotherapy, integration of chemotherapy, improvement in tumor imaging, and disease monitoring. Doses recommended for nasopharyngeal carcinoma are 66 to 70 to the gross disease and 50 to 60 gray for elective treatment of potential subclinical sites. Treatment options are mainstay is radiotherapy with or without chemotherapy. So it's only in stage 1 or stage 2 T2N0 where RT alone approach can be used. In stage 2 where it is node positive, or stage 3 or stage 4A, nasopharyngeal carcinoma is treated with concomitant chemoradiation. The evidence for this comes from the intergroup 0099 study by Al-Sarraf M. et al. They included all T3, T4 and node positive with chemoradiotherapy followed by adjuvant radiotherapy. And they showed that there was a significant improvement in overall survival. This was one of the first few trials which showed improvement in overall survival with concomitant chemoradiotherapy. In fact, the trial was closed early for this reason. Also, the chemotherapy, the concomitant chemotherapy that they used was cisplatin, and the adjuvant chemotherapy, cisplatin as 100 milligram per meter square 3 weekly, and they also gave adjuvant chemotherapy to these patients, and which was cisplatin and 5-FU. Now, the RTOG 0225, this trial, again, they included T2 also and node positive disease. And they have also shown that this subgroup of patient benefits with chemoradiation. So RT alone is reserved for only stage 1 disease or maybe stage T2 and 0. But the radiotherapy has to be IMRT if we are doing RT alone. So for the sake of completion and to know how the radiotherapy for nasopharynx has evolved, I would spend some time on 2D radiotherapy as well. And the workflow we know is positioning and immobilization, simulation, field designing and arrangement, and looking at the control and the complication rates. When 2D radiotherapy is planned, patient is set up in supine position with head extended, supported with headrest. The extension is such that the extension of the head is such that the tip of uvula and base of occiput are on a parallel plane to beam axis. Wires are used to mark the grossly involved lymph nodes and the lateral canthi of the eyes. Immobilization with thermoplastic cast covering head to shoulder region. Conventional simulation from skull vertex to at least 2 to 5 centimeter from head of clavicle is done. Now the volume to be irradiated, it is frequently asked question that the volume to be irradiated in carcinoma nasopharynx includes the entire nasopharynx, adjacent parapharyngeal tissue with margin, posterior ethmoid cells, posterior 1/3 of the maxillary antrum to cover pterygopalatine fissure and cavity, all of the cervical lymph nodes from level 2 to level 5A. And the boost volume includes the gross disease with 0.5 to 1 centimeter margin. Now, to cover these areas, the field arrangement is 2 lateral opposing fasciocervical fields with a matching low anterior cervical field for lower cervical lymphatics. Now, the lateral fields, for the lateral opposing fasciocervical fields, the borders are for T1 to T2 lesion at the floor of the pituitary fossa and just above the clivus. For T3 to T4 lesion, an initial margin of 2 centimeters is taken beyond the tumor, and extension into the clivus or intracranially is done. The inferior border is just above the thyroid notch or arytenoids. Anterior border is at posterior 1/3 of the nasal cavities, depending upon the size of lesion. If the tumor is extending into the nasal cavity, we have to keep the anterior border 2 centimeters beyond the tumor extension. And the posterior border is just behind the spinous process. So this is the phase 1 lateral opposing facio-cervical field borders for conventional radiotherapy of carcinoma nasopharynx. Now, there are specialized shielding arrangements required when we are treating these volumes. We have to shield the brainstem with a 5 HVL block in a manner that it is 0.5 centimeter behind the upper edge of clivus and 1 centimeter below the lower edge of the clivus. The eye needs to be shielding with a 5 HVL shield placed 1.5 centimeter behind the lateral canthus of the eye. Remember, during simulation, we have marked it. Posterior tongue is also shielded with standard blocks, and the pituitary and the temporal lobes are also shielded in the upper half of the pituitary fossa. This we are doing because of the risk of the temporal lobe necrosis if we give a dose higher than 60 gray. The low anterior neck field, its upper border matches the inferior border of the lateral cervical facio-cervical fields, and the inferior border is 1 centimeter below the clavicle. Laterally, we extend it to include medial 2/3 of the clavicle. Now, phase 2. This is the modified host technique, and in phase 2, that is after a dose of around 44 to 46 gray, we shrink the posterior margin to posterior 1/3 of the vertebral body. Initially, we were at the spinous process. Now we have shrunk the posterior margin, and the inferior margin is now at the level of mid-tonsillar fossa. The superior margin remains the same as in phase 1. And now the difference in this phase 2 is that we add an anterior cervical field. It's a non-coplanar beam, and the eye is shielded. And this we do so as to give appropriate dose to the nasopharynx while reducing the dose to the temporal lobes. Now we have in this slide the sagittal view and coronal view of the lateral opposed facial fields and the non-coplanar anterior facial field for phase 2 of the nasopharyngeal carcinoma treatment. In the low anterior cervical field, we shield the midline for lesser dose to the structures in the midline. This 3-field technique minimizes the dose to bilateral temporal lobes and the temporomandibular joint, and it was frequently used with 2D radiotherapy techniques. Alternatively, if there is involvement of the oropharynx or gross neck nodes, then phase 2 is done only by shrinking the posterior field and treating level 5 lymphatics with electrons. So in phase 3, while doing conventional radiotherapy, we boost only the gross tumor and the nodes with a margin of 0.5 to 1 centimeter. This is to keep the dose to optic nerves, chiasm, and optic tracts within the tolerance of 54 gray. Now, IMRT has an important role to play in the management of nasopharyngeal carcinoma. Radiotherapy to nasopharyngeal carcinoma should be given at a high volume center which are equipped with IMRT, because it has been seen that the outcomes are improved and there are less severe side effects as compared to conventional 2D and 3D radiotherapy. A meta-analysis has shown that 5-year OS and 5-year local control favors IMRT over other techniques. So this is one side because of the steep dose gradients that we require to limit the dose to organs at risk. One should consider IMRT for radiotherapy. Again, evolution of treatment, this was published in 2014, and it was seen that across all stages, especially in stage 3 and 4, there was a significant improvement with IMRT in overall survival, and also the major late toxicities, the neurological toxicities such as temporal lobe necrosis, brainstem damage, and cranial neuropathy. There was a significant reduction if IMRT was used as compared to 3D CRT or 2D RT. Now, coming to the positioning for IMRT, for IMRT, the supine position in neutral neck position on a flat tabletop of simulation CT scanner is used. Immobilization devices is mostly a 4 to 5 fixation point thermoplastic mask. Thin CT sections, preferably 2 mm, should be acquired from vertex to 2 cm below the sternoclavicular joint, ideally with IV contrast enhancement, and all measures should be taken to ensure the availability of optimal image sets for planning with MRI, FDG PET images. Now, there have been various guidelines for delineation of the target volumes. In detail, I would be discussing the guideline by Lee et al. They have considered all the studies and various trials and incorporated into these guidelines. They were published in 2017. And the recommendations to guide clinicians in contouring are applicable to all histologic subtypes of nasopharyngeal carcinoma. So published in green journals, these international guidelines for delineation of clinical target volumes for nasopharyngeal carcinoma, they have 3 CTVs, the high risk CTV, the intermediate risk CTV, and the low risk CTV. The primary CTV, which is high risk, is irradiated to full therapeutic dose of around 70 gray, and GTV with a 5 mm isotropic margin, and clivus is excluded if it is not involved. However, some researchers, they include the whole nasopharynx and GTV with 5 mm isotropic margins. The borders of nasopharynx, as we discussed previously, are base of skull, anteriorly junction with nasal choana, laterally medial border of parapharyngeal space, and caudally lower border of C1. Now, the intermediate risk CTV, as per these guidelines, include 5 mm expansion from the primary CTV 1, or it is GTV plus 10 mm isotropic margin, because CTV P1 was GTV plus 5 mm isotropic margin. So CTV P2 is GTV plus 10 mm isotropic margin, plus superiorly ethmoid sinus, the posterior ethmoid sinus, sphenoid sinus, inferior part in T1, T2, and the whole sphenoid sinus in T3, T4 disease, cavernous sinus only if T3, T4 disease. Anteriorly, posterior maxillary sinus, cover 5 mm electively to ensure inclusion of pterygomaxillary fissure and pterygopalatine fossa, irrespective of T category. Posterior nasal cavity, cover 5 mm anteriorly from choana, irrespective of T category. Laterally, the pterygoid muscle is covered with expansion from GTV of 10 mm, and parapharyngeal space in all T categories, entire parapharyngeal space needs to be covered. Clivus, as I mentioned, cover anterior 1/3 if uninvolved and whole if it is involved. The skull base foramina need to be covered by lateral foramen ovale, foramen rotunda, and lacera, irrespective of T category. Nodal CTV. The CTV N1 or the high risk nodal CTV is the nodal GTV plus 5 mm in case if there is no extra capsular extension as per CLE guidelines. But if there is extra capsular extension, we need to consider 10 mm of expansion. CTV N2 or intermediate risk nodal CTV is 5 mm expansion to nodal CTV 1 plus all the current guidelines, the ASCO, the Chinese and these Lee guidelines recommend elective coverage of bilateral nasopharyngeal and cervical nodal levels from 2, 3 and 5A within intermediate risk CTV for all patients. Now level 4B and 5B if there is any involved nodes on the same side of the neck. Important is the elective coverage of level 1B lymph nodes within the intermediate risk CTV. Level 1B nodes are included in intermediate risk CTV if there is gross involvement of anterior nasal cavity because it drains into level 1B, or if there is gross involvement of level 2 nodes. In some centers, there are only high risk or intermediate risk CTV, but at others, there is a low risk CTV also for a lower prophylactic dose of about 50 gray for level 4 and 5B, if nodal involvement is confined to level 2 only. PTV is not given by these current guidelines that I am discussing by Anna W. Lee et al. But some other studies have suggested a PTV of 3 to 5 mm depending upon whether IGRT is used or not. A representation, the GTV is in blue, the CTV 70 or the high risk CTV is 5 mm isotropic margin to GTV, and CTV 60 or the intermediate risk CTV includes the parapharyngeal space and is given in purple for the for a T2 nasopharyngeal cancer. Now, dose prescription in IMRT. So the most commonly followed is SIB IMRT dose schedule with 2.12 to the high risk CTV in 33 fractions, and then it is around 69, and then it is a dose of 69.96 gray total dose, as 1.8 gray per fraction to intermediate risk CTV, it is 59.4 gray to CTV2, and 1.64 gray per fraction in 33 fractions, it is a total dose of 54.12 gray to the low risk CTV. The critical organs at risk are brainstem, optic nerves, and optic chiasm, which have a tolerance of Tmax of 54 gray. The cord, which has a Dmax of 45 gray. The temporal lobes, to which the dose should be limited to 60 gray. And also, if we give higher fractions, a higher dose per fraction, then the damage to temporal lobe is increased. The mandible and TM joint Dmax less than 70 gray, the brachial plexus Dmax less than 66 gray. For the parotids, the D mean is less than 26 gray to be achieved in at least one gland, or at least 20 cc of combined volume less than 20 gray. At least 50% of the glands less than 30 gray. Now, outcomes of IMRT. It has been seen that with IMRT, for stage 3 and 4 disease, overall survival has been about 80% at 2 years. Local control has been 93% at 2 years. And at 4 years, it has been overall survival also is good. So now the role of chemotherapy. The neoadjuvant chemotherapy with a multi-agent chemotherapy regime prior to definitive chemoradiotherapy has been shown to improve survival, but with increased hematological and gastrointestinal toxicity in a recent meta-analysis of 7 randomized controlled trials. Now, this is very interesting. We began with RTOG 0099, or the study by Al-Sarraf et al., where they were using chemoradiotherapy followed by adjuvant chemotherapy. They used chemoradiotherapy, single agent cisplatin, adjuvant radiotherapy, cisplatin plus 5-FU. Now, various trials have seen that instead of adjuvant chemotherapy in stage 3 or 4 disease or with node positive disease, if induction chemotherapy is done prior to chemotherapy, chemoradiotherapy, then it is well tolerated and there is lesser risk of distant mets. NCCN guidelines recommend platinum gemcitabine as preferred induction chemotherapy and TPF regime as induction chemotherapy for Epstein-Barr virus associated carcinoma nasopharynx. But there is still no head-to-head comparison with other regimes, and the optimum option remains to be defined. Another evidence for induction chemotherapy and chemoradiotherapy in locally advanced nasopharyngeal carcinoma comes from the SUN trial, in which around 500 patients with induction followed by chemotherapy versus chemoradiotherapy alone showed improved overall survival and distant mets-free survival. NPC 0501 trial compared benefit of changing the chemo sequence from concurrent adjuvant, which was there in intergroup 0099, to induction concurrent in stage 3-4B, and subgroup analysis adjusted for other factors suggested improved 5-year overall survival. So we have treated in recent past, in 2021, 2 patients with carcinoma nasopharynx. Unfortunately, both these young males had locally advanced disease. This first case is of a 13-year-old boy who had a nasopharyngeal mass extending to bilateral choana, oropharynx with bilateral parapharyngeal spaces with erosion of sphenoid, sinus, and clivus. And bilateral level 2, 3, 4, and 5 nodes were involved, and the histopathology was non-keratinizing squamous cell carcinoma of the nasopharynx. Remember, I mentioned that this variety has a good local control but higher risk of distant mets. So we took up this patient for induction chemotherapy, cisplatin 5-FU, 3 cycles, and then chemoradiotherapy along with concurrent cisplatin. The volumes that we irradiated were those prior to the induction chemotherapy. And this was the dose that we achieved. However, at 6 months after completion of his adjuvant chemotherapy, he developed lung, liver, and bone mets. But the PET CT showed that he had a very good local control. So we lost that patient to follow up after that. But as is the natural progression of the disease, his natural history of this disease, he was locally controlled but had distant mets after completion of the entire treatment. So this is another case of a young boy who presented with very advanced local and nodal disease. In this case, we have given induction chemotherapy with TPF, docetaxel, cisplatin, and 5-FU, and treated with chemoradiotherapy to the pre-induction chemotherapy volumes. Patient is still on chemoradiotherapy and he's tolerating it well. This is the VMAT IMRT plan for the second patient. So for the sake of completion, I am also covering brachytherapy. Brachytherapy in nasopharynx was used as boost of T1 to T3 carcinoma of nasopharynx. With IMRT, there is not much role of brachytherapy. The techniques were temporary intracavitary application, temporary interstitial implantation or permanent interstitial implant, and the dose rate can be LDR or HDR. The applicators, various available applicators are mold, the Levendog, Forzu. Forzu is a rubber applicator. The most interesting is the applicator by Levendog or the Rotterdam nasopharyngeal applicator. It is made up of silicone, it is flexible and conforms to the 3D geometry of the nasopharynx. It fits closely to the base of skull and situated at a fixed distance from the soft palate. And I was inquisitive about how would a nasopharyngeal applicator be placed inside the nasopharyngeal cavity. So I have included this slide of method of placing this Levendog applicator in the nasopharynx. First, a pediatric feeding tube is introduced into the nasopharynx and withdrawn from the mouth. The Rotterdam applicator is then guided intraorally over the pediatric tubes into the nasopharynx and the nasal cavity. After positioning of the applicator in nasopharynx and nasal cavity, the feeding tubes are withdrawn and the applicator is placed. So this is for the interest of the PG students, how a nasopharyngeal applicator can be placed. The doses doses with brachytherapy depend upon the previous ABRT doses. If 60 gray has been already delivered by conventional treatment, then 3 gray 2 fractions per day for 6 fraction. If 70 gray has been delivered, then 3 gray per fraction as 2 fractions for 4 fractions is delivered by HDR. Now there is more and more interest in the proton therapy or carbon ion for treatment of this difficult to treat site, which is close to OAR, has a concave CTV, and the potential benefits of adaptive intensity modulated proton therapy in nasopharyngeal carcinoma is being looked into. This Sapporo University study showed significant better sparing of supraglottic larynx, oral cavity, dysphagia associated structures and auditory structures using proton therapy compared to IMRT with photons. The mean dose to oral cavity, supraglottic and glottic larynx were reduced by around 20 gray. So these are the dose distributions with IMRT done with X-rays, and these are the dose distribution with intensity modulated proton therapy. And we can see that the dose to the neural structures and the oral cavity and the central structure is reduced. However, the clinical data is limited and needs larger studies and more follow-up to establish the role advantage. The sequelae of treatment of radiotherapy to nasopharynx are temporal lobe necrosis. The temporal lobe necrosis presents as partial absence seizures or memory loss, and on doing neuroimaging, it can be made out. Then there is hearing loss, xerostomia, as I mentioned, can be lesser with IMRT. However, at 2 months, the salivary flow was not much different, but over time, over 1 year, the salivary flow, the subjective one improved. For objective, there was an increased salivary flow. However, we need mucus from the minor salivary gland for patients to feel better. So that was not seen, even if the xerostomia, even if the dose to parotid glands was lesser. Neck fibrosis, cranial nerve dysfunction, endocrine dysfunction, soft tissue necrosis, osteonecrosis, which is rare, transverse radiation myelitis, or the Lermit syndrome, the feeling of an electric current when the patient is changing clothes. So these are the treatment sequelae, and patient needs to be followed up with a history and physical examination at every 3 months for the first year, along with a nasopharyngoscopy done after 3 months of completion of treatment, followed by a 6-monthly clinical assessment for 2 years, and then yearly till the 5 years of completion of treatment. Imaging for signs, symptoms, or if there is continuation of smoking needs to be done. As the neck has been irradiated, at 6 months after treatment, baseline TSH needs to be checked and then repeated every year. Speech, hearing, dental evaluation, cessation of the smoking needs to be counseled every time patient visits the OPD. There is some role of Epstein-Barr virus DNA in post-treatment surveillance, but whether one should change the treatment depending upon the EBV DNA is still under investigation. So I would like to again emphasize on the fact that treatment of carcinoma nasopharynx is a gratifying challenge for a radiation oncologist. It's a challenge because it is difficult to detect, being a silent, deep-seated tumor. The treatment is difficult because of its anatomical proximity to critical structures, and thus need to prefer highly conformal or IMRT. Role of surgery is limited to biopsy and salvage. It is gratifying because they are highly radiosensitive and chemosensitive tumors. For stage 1 disease, while RT alone is sufficient, in stage 2 onwards, there's a role of chemoradiotherapy. And for stage 3 or 4A disease, it is either induction therapy followed by chemoradiotherapy, or for those patients who are ineligible for induction therapy, adjuvant chemotherapy after chemoradiotherapy is to be considered. I thank you all for your kind attention.
Ma'am, it was an interesting lecture, and thank you so much. I have revised so many things. One question that is lying in the chat box is how to localize clivus clinically for second planning.
I have mentioned the guidelines by Lee et al.
Yeah.
And
yes.
So they can be referred to for delineation of the clinical target volume for high risk and intermediate risk.
Yeah, ma'am. In intermediate risk, as you have mentioned, part of clivus, and in high risk, the whole clivus has to be controlled.
Yes, some clinicians consider the entire clivus, but there were many who said if it is a T1, T2 disease, only a part of clivus is to be included is enough. So there was not absolute consensus, but most were in favor of including it partly.
Yes, ma'am. And I think when we are planning for carcinoma nasopharynx, we should understand it is entirely different from other head and neck cancers.
That's true. That's true.
Am I right?
Hello, doctor. Can you please repeat, Dr. Rashi? There was a disturbance in.
Yeah. Actually, I was saying the contouring of carcinoma nasopharynx. Actually, it is a lengthy process. We cannot contour within few hours. We have to take time, and it is entirely different.
That's true. That's true. It is entirely different, and one needs to do proper imaging, that is an MRI, and if possible, contrast enhanced CE-CT simulation must be used, and fusion can be tried. And it is very important because it is very close to critical neural structures, and we need to give high doses. So the dose gradients are steep. So one needs to be very careful, and but yes, again, as I mentioned, if we are able to push in the doses to the tune of 70 gray with SIB IMRT, then the results are also very good, especially for limited disease. And
Yeah, ma'am.
and perhaps it is not a site which should be treated with 2D RT as of now in present era. One needs an IMRT setup for at least for treatment of carcinoma nasopharynx. So,
Yeah, ma'am. Actually, I want to share my experience. I have seen one patient whose growth was actually invading cranium. So we were thinking patient will not survive. But that cranial extension, intracranial extension, patient responded very well to radiotherapy.
yeah, that is true.
So
So in the cases that I've shown, the young boy who was 13-year-old, and he really, his nodes melted, and when he presented to us, all the level of nodes could be seen clinically, and on CT, the simulation CT, we could very well demarcate all the nodal levels in his case. But there was a very good response to chemoradiotherapy. On PET CT also, no disease was detected loco-regionally, but unfortunately, he had mets in liver and the bone, and so yes, had it not metastasized, perhaps we would be still having that patient around. So
another question is PET CT is necessary for contouring?
otherwise, an MRI is sufficient, but PET CT is only if we have a suspicion of metastatic disease, or if there is a node for which primary is unknown. Sometimes a PET CT then detect that the primary is lying in the nasopharynx. So if it's a neck node with primary unknown, then PET CT has a role. Otherwise, we have not been doing PET CT in all cases. We do with MRI only, and a contrast and simulation CT.
Yes, ma'am. And I think this is the site in which knowledge of all foramens is very important.
Yes, all the foramens and the structures passing through all the foramen. It is in itself an anatomical challenge to understand and learn. But if we are following the guidelines, we mostly are able to achieve the results that we wish to. One needs to be careful and then work on it. Yes, and you are right, it takes time. It cannot be treated as another head and neck cancer. It is a totally different disease.
Ma'am, one more question. Although you have mentioned if the patient is positive for Epstein-Barr virus, is there any difference in treatment?
Some studies have suggested that if there is a high titer of Epstein-Barr virus DNA after treatment, then patients are to be considered for adjuvant treatment with chemotherapy such as capecitabine. But there has not been much evidence, so I left it at that. They're still looking into it. In surveillance, they are looking at the titers of Epstein-Barr virus DNA, and but detecting a higher titer prior to treatment, during treatment, does not change our treatment protocol per se, which remains chemoradiotherapy, either with induction if it is a locally advanced disease, or if induction cannot be given, then with adjuvant chemotherapy.
There's no change in the dose. I just want to ask, is there any change in the radiation dose if it is EBV positive?
No.
At the same dose.
Yeah, although all the viral associated tumors like the HPV associated oropharynx and the Epstein-Barr virus associated nasopharynx, they both have good local control and a higher propensity for distant mets. But as in HPV, they are not still, as of now, looking at decreasing the dose for Epstein-Barr virus associated DNA. There have been no studies in this regard.
Dr.
Okay,
Rohini,
another
this is regarding your practical
No, no,
issues
no.
during taking setup of young children's.
Yes, they need to be relaxed at what they need, perhaps before going ahead with the simulation procedure. The CT one needs to make them comfortable with the immobilization devices and a friendly environment. Only when they are comfortable and relaxed, it will be ensuring that the treatment position is achieved. The same treatment position is achieved at the time of simulation and during treatment. So one needs to, not rush into doing the procedure, completing the simulation procedure when there are young children around. One needs to give some time, make them comfortable, take the help of the nursing staff or others around, and make them feel as if it's a toy, or it's a playing a game that they are playing, wearing a mask and lying down. So we have tried it with quite a few patients, and fortunately till date it has worked. And a small toffee or chocolate also helps.
Yeah, ma'am. I request Dr. Shaleen to comment or suggest anything. Dr. Shaleen sir is president of UPRI.
So, thank you very much, Roni. I'm sorry, I'm sitting in a very noisy environment, but I'm traveling. Uh, uh, I particularly, it was very gratifying to see that you have included 2D planning, and that is important both from the point of practical applications currently, as we are, not everybody has access to therapy, but also it's important to see history. And you've taken hose techniques and the anterior field. We've never delivered the anterior field when there's anterior extension and there's differential weighting. But I remember we've done all this planning and moved our way up now to contouring, segmentation, and conformality, which is fine. Uh, I really have nothing to add to your presentation. It's been very comprehensive, and thank you very much. That's all I would say.
Thank you, sir.
And I am not certain about EDV. I don't think those de-escalate. I
No,
do
sir,
not
they
think
don't.
there's
No,
any
sir, they
data.
don't.
Yes,
They
there is
don't.
no data. As
No,
far
no,
as I
no.
know, they
No,
do not
sir.
those de-escalate. What is the evidence? I was wondering for the incremental gain of TPF over PF. Is there a randomized trial to that effect?
Yes,
If you have
sir.
reviewed literature,
Yes, sir. There is. There is, sir.
and the
There are
differences in PFS or OS,
the differences in OS, sir. They have seen.
significant? Significant?
Yes, sir. They have shown now they are moving towards TPF, and previously they were considering cisplatin and gemcitabine. So now they are considering TPF as induction therapy. So this is one site in which I saw that in head and neck there is considerable interest in induction chemotherapy as compared to upfront CTRT in cases of locally advanced disease. But
Sure, all for the right reasons. You see, you have to have the tumor implode first, so you have more favorable characteristics. You treat the same area, but you cannot treat the same volume. You will treat the same geometric location in the anatomical areas because the volume tumor implodes and it's chemosensitive, it's radiosensitive. We understand that.
yes,
So
sir.
the volumes change. The other problem that happens is if you don't give induction chemotherapy, that because the tumor reduces in volume, so there are dosimetric changes that are far more dramatic in nasopharynx, particularly in neck nodes, even in the primary site. And
That's
so the
true, sir.
replanning requirement is there. That's the
Yes,
second advantage of induction chemotherapy that we see.
yes, sir.
Distant metastasis remains a problem, as you pointed out. That's correct.
The compliance also improves, sir, if it is given in
Absolutely.
induction.
They feel gratified.
Yes, sir.
They can see the response. It's gratifying.
Yes, sir.
Yes, absolutely. Thank you very much.
Thank you, sir.
Nothing. Thank you so much for taking time out. So very grateful
Thank
to
you.
Dr. Surbi, Dr. Rashi, and everybody else. Thank you very much indeed.
Thank you so much, Dr. Rohini, for such a comprehensive lecture. You covered 2D planning, 3D planning so well. I think it's very useful our residents and other participants who are present here. Thanks once again from behalf of UP chapter AORI. Thank you, Dr. Rashi, for moderation, for such an interactive moderation. Thank you, Dr. Salim, sir. And thank you all the participants present here. Thanks once again.
Thank you.